The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone and welcome to tonight's webinar, Advancements in Treating Rectal Cancer. A couple of housekeeping notes. Tonight's speaker is Dr. Deborah Schrag, and I will introduce her here to you in just a moment. For those of you on tonight who know of folks who want to listen in and didn't get a chance to do so tonight, all of our webinars are archived on our website. They're at the link listed. There will be a follow-up survey that comes out to you via email, and we send you a free Blue Star of Hope pin, so we do appreciate your feedback. If you could take time to do that, that would be great. We have already some questions from some of our attendees already, but if you'd like to ask a question during the webinar, you can do so in the right-hand side panel of your screen, or you can call the Fight Colorectal Cancer answer line at the number listed there. So our disclaimer here at Fight Colorectal Cancer is basically that the information and services provided by Fight Colorectal Cancer are for general information purposes only. And we do have a monthly patient webinar series. So what that means is we do these webinars on the third Wednesday of every month. And the next one coming up is actually in June, on June 19th, about colorectal cancer and what's kind of new and what's on the horizon for colorectal cancer patients. And we're doing that in collaboration with the Colon Cancer Alliance. And you can register for that webinar there at our website at fightcolorectalcancer.org. So to the most important part of tonight's presentation, our speaker, Dr. Deborah Schrag from the Dana-Farber Cancer Institute. She has received her medical degree from Columbia University in New York. She subsequently completed her residency in internal medicine at Brigham and Women's Hospital and her fellowship in medical oncology at the Dana-Farber Cancer Institute. She's obtained a master's in public health from the Harvard School of Public Health and then joined the staff there at Dana-Farber. From 1999 through 2007, she practiced medical oncology in the Division of Gastrointestinal Oncology at Memorial Sloan Kettering in New York, where she was an associate member and associate professor of public health and medicine. In 2007, she returned to Dana-Farber Cancer Institute, where she is a medical oncologist and a clinical investigator in the Center for Gastrointestinal Oncology. And her research focuses on the utilization of new cancer treatment technologies. So it is our pleasure to have her here with us tonight. Thank you so much, Dr. Schrag, and I will turn things over to you.
Thank you so much for that very kind introduction. And thanks to those of you who are listening to this webinar. I look forward to your questions and to a lively discussion. Maybe I should start out with a little disclaimer, which is when we talk about colorectal cancer, we so often lump colon and rectal cancer together. And this evening, I'm going to talk about rectal cancer. Many aspects of treating colon and rectal cancer are similar, particularly when the cancers spread to distant organs. Essentially, the way we treat the cancers with chemotherapy are the same. But this evening, I'm really going to focus on rectal cancer, which is about 30% of all colorectal cancer, and a condition that affects approximately 30,000 Americans each year. Next slide. So the American Cancer Society estimates about 40,000 new cases of rectal cancer in 2013. Colon and rectal cancer is the third leading cause of cancer-related death in the United States. But if you take just rectal cancer, it's about as common as our most common forms of leukemia or lymphoma. So just talking about rectal cancer, this is not a rare condition. So I know people often feel when they have a new diagnosis of rectal cancer that there's a stigma or it's embarrassing to say rectal cancer, but you are not alone. There are 40,000 Americans each year, and fortunately by now millions who have been treated successfully for the disease and are survivors. Next slide. The death rate from rectal cancer has been dropping for more than 20 years. Today, there are more than 1 million colorectal cancer survivors in the United States. It's actually increasingly getting difficult to count just how many there are. And all of this is a result of advancements in screening and early detection, as well as better treatment. What I'm going to talk about tonight is how we get there. When we think about treating rectal cancer, we really divide it into distinct set of phases. There's detection, which I'm not going to dwell on tonight, the workup and evaluation when we suspect someone has a new case of rectal cancer, the staging that goes on to figure out just how extensive the disease is, and the staging informs the identification and specification of a good treatment plan. When treatment is complete, patients enter into a monitoring program that we call surveillance. Sometimes it's called post-treatment surveillance, and that typically continues for a period of approximately 5 years. And at that point, most patients are able to return to the care of their primary care physician, knowing that their cancer team is ideally only a phone call away. Next slide. As you probably know, screening for colorectal cancer is extremely effective. Screening for the routine population starts at age 50. So 50th birthday present, get a colonoscopy. Exceptions to this policy, which is widespread across the United States, I'm sure you've all heard of the colonoscopy screening campaigns, are for patients who have a family member who was diagnosed at a young age, who are at high risk for a familial form of a colorectal cancer, have had a prior history of polyp, or any one of a number of rather rare high-risk conditions, such as ulcerative colitis. The most comprehensive screening tool is colonoscopy, which visualizes the rectum. So it doesn't have the word rectum in the title, but a colonoscopy also visualizes the rectum. The colonoscopy is inserted into the rectum and looks at the rectum carefully and goes all the way through the entire colon to the cecum. And the other major component of workup includes staging, with what starts out with most typically a CT scan. Next slide. So the phases of workup include obtaining a biopsy of suspected tumor with very careful review by pathology. Essentially what happens is that during a colonoscopy procedure, not always, but it's usually during a colonoscopy procedure, the endoscopist, the person performing that, who could be a surgeon or often is a gastroenterologist, takes a small sample of tumor tissue. This is not a painful procedure, and delivers it carefully in a specimen kit to the pathologist, who examines it under a microscope. Why do we do this? Well, we do it to discover the presence, cause, and extent of the disease, and increasingly to evaluate the presence of any molecular changes that might be present in the tumor specimen. We perform colonoscopy and proctoscopy. Proctoscopy is just a short colonoscopy, looking only at the first part of the colon, really the rectum. And essentially the idea is to look for the extent of disease, how large is the lesion, are there other lesions, because we know that people who have cancers of the rectum also have polyps elsewhere throughout the colon. And we don't like to take people to the operating room to operate on one cancer when there are other polyps nearby that may also need to be removed. Often, we call colonoscopy and proctoscopy, these procedures are not simply diagnostic, they're also therapeutic. In other words, the screening tests, colonoscopy and proctoscopy are screening tests, they are also used to diagnose cancer and treat cancer, because the earliest stage colorectal cancers can be removed right then and there during the endoscopy. The next component of workup is a CAT scan. And workup of colorectal cancer should include a CAT scan of the chest, abdomen, and pelvis. Because of the anatomy and the way the blood vessels drain the colon versus the rectum, rectal cancers are a little bit more likely to spread through the circulation that doesn't go directly to the liver. We call that the systemic circulation, up through the inferior vena cava. And therefore, rectal cancers are a little bit more likely to end up in the lung. Sometimes people do not order a CT scan of the chest as part of the staging workup, but this is, in fact, a very important component. And this is part of staging to see how extensive the disease is. And the extent of the disease determines the appropriate treatment. The other important component of workup is a blood test called a CEA. CEA is short for carcinoembryonic antigen. This is a protein that is associated with many tumors, including colorectal cancer. Not all colorectal cancers are going to make this protein, but the ones that do, it can then be useful to track the status of the disease. It's important to emphasize that not having a detectable CEA test doesn't mean that there is no cancer, and the converse is also true. Particularly for the rectum are two staging tests that are very useful to evaluate the tumor deep in the pelvis. We all know that right near the rectum are lots of other important structures in both women and men. It's a crowded, small area that's very important to our functioning and our quality of life. And there are a couple of imaging studies that provide not better detail, but different detail, a different way of looking at those tumors that today are considered part of the standard workup of rectal cancer, but these are not required for colon cancer, where they really don't add any value. These two tests are an endorectal ultrasound or a pelvic MRI. It is not necessary to do both, but one or the other is recommended because they provide a detailed view of the rectum. They tell the surgeon who's going to ultimately perform the procedure to remove the rectal cancer how deep the tumor has penetrated into the wall of the rectum. The rectum is covered by an envelope called the mesorectum. And in order to get all the tumor out, the surgeon really wants to visualize how close the tumor is to this envelope. And is the surgeon going to be able to remove the tumor completely with what's known as clean, clear margins? These two imaging tests, the endorectal ultrasound or alternatively the MRI, give the surgeon valuable information that help them plan the best operation. In addition, sometimes if these imaging tests suggest that the tumor has sent tentacles out or is pressing on regional structures, it would tell team members that radiation is a particularly important component of treatment, or that some chemotherapy before the operation would give the surgeon an advantage and help them perform a better operation. So again, not necessary for colon cancer, but for rectal cancer, either an endorectal ultrasound or a pelvic MRI in addition to the CT scan. Next slide. Staging. Staging describes the extent of the cancer in the body and where it spread. How far has the main tumor grown into nearby areas? What is the extent of spread to regional lymph nodes? Has the cancer spread, and you often hear the word metastasized, to other organs of the body, remembering that rectal cancer likes to spread to the lung a little bit more often than colon cancer. The staging is an important factor in determining prognosis, how well we can expect someone will do, and also helps to determine the best treatment options. Staging consists of physical examination, the biopsies, the evaluation by pathology, as well as the imaging tests, as well as blood tests. Next slide. Treatment for rectal cancer consists of three dominant components: surgery, radiation therapy, and chemotherapy. However, these are the three main ways that we treat rectal cancer, but of course we often involve many other specialists and care providers and members of the team. That might include nutritionists, It might include experts in anesthesia and pain management, experts in psychosocial health and helping people cope with the emotional aspects of illness. So there are often many more than these 3 team members involved. Surgery is typically the main primary treatment for rectal cancer, but radiation and chemotherapy are usually given either before and or after surgery. The purpose of surgery is for the surgeon to remove the tumor and the surrounding tissues with what's known as clear margins. We want the surgeons to be able to get all the tumor out because we know that that correlates with the ability to keep patients cancer-free over the long run. Next slide. So just briefly, I want to touch on a few advances in rectal cancer surgery. Over the past decade, there have been advances in techniques, equipment, and surgical specialization that have enabled surgeons to perform more precise excision that have allowed patients to avoid having ostomies, not always, sometimes that's not possible, but more often, and to have better quality of life and better what we sometimes, this is hard for people to say, but better bowel function and better sphincter function, which translates into fewer accidents, less needing to run to the bathroom and being left with persistent diarrhea. Some of the tools include the availability of stapling devices, the availability of techniques to preserve continence, such as the J pouch and the coloplasty pouch. There's also been a much better attention to the ability to obtain what's known as cancer clearance through a technique known as total mesorectal excision. Total mesorectal excision is often known as TME, and anyone who undergoes rectal cancer today wants to have the surgery from a surgeon who knows how to do a TME resection. TME means not simply taking out the rectum, but taking out the rectum with its envelope. The rectum sits inside a glistening sheath of tissue that's a little bit like saran wrap, and we know that taking the rectum out intact without disrupting that tissue plane means that over the long run, the cancer is less likely to come back right in that same spot in the pelvis. So that's been a very important advance. These days in the United States, all board-certified colorectal cancer surgeons are trained in this technique. There's still some general surgeons who are not familiar with this technique. Those are typically surgeons who spend most of their time doing other kinds of work, maybe breast surgery or taking out gallbladders or doing all types of surgery. And this is sometimes a challenge for surgeons in rural parts of the United States who are a big country, and if you're in a very rural area and you may not do a lot of rectal cancer, well, in that case, it's probably worth taking a drive to have your surgery from someone who is trained in total mesorectal excision or TME. There are also some advances in microsurgery and other lots of techniques that I won't get into in detail, but these have resulted in better quality of life for patients. Next slide. So radiation therapy. Radiation therapy, as most of you probably know, consists of high-energy rays or particles that are designed to destroy cancer cells. Radiation can lower the risk that cancer will come back and improve operability, or the ability for the surgeon to, quote, get it all. So some radiation, when delivered before an operation, can help the surgeon increase the likelihood of getting clean margins and being able to do that perfect TME resection. Next slide. Advances in radiation therapy include external beam radiation therapy, endocavitary radiation therapy, and brachytherapy. But none of these techniques has been shown in rectal cancer to be clearly superior to the standard approach. So you may hear about these things, but the standard that's really used in treating rectal cancer is external beam radiation therapy. And typically what happens is patients will undergo a simulation where the radiation oncologist plans exactly how to direct the radiation beam so that it maximally hits the rectal tumor itself with as little scatter as possible to normal healthy tissues, because we want to avoid radiating normal healthy tissue because that's what causes side effects both in the short term and over the long term. Next slide. Chemotherapy can be administered either before or after surgery. Some of the drugs used to treat rectal cancer are 5-fluorouracil, capecitabine, sorry for that typo, that should be an E, irinotecan, and oxaliplatin. Capecitabine is an oral pill form of 5-FU, so those first two drugs are really functionally, they're the same. One's an intravenous form and one's an oral form, and they work quite similarly. Next slide. So advances in chemotherapy. There are a number of regimens or combinations of drugs that are used to treat rectal cancer. They include regimens that you may have heard of, such as FOLFOX, FOLFIRI, FOLFOXIRI, CAPOX. These are lots of different agents. For patients who have localized disease, the mainstay of therapy is FOLFOX, or for patients who are a little bit more frail or elderly or have multiple other medical problems, 5-FU and leucovorin alone without the oxaliplatin is also reasonable. That is the first regimen that I've listed there, FOLFOX, or just the first two of the ingredients in FOLFOX, the 5-FU and leucovorin. For patients with more advanced disease or who've received FOLFOX and it hasn't worked, then the cancer has unfortunately come back, then we consider the other regimens that are listed below, the FOLFIRI, the FOLFOXIRI, CAPOX, sometimes with addition of biologic agents such as those we've listed below, bevacizumab, cetuximab, or panitumumab. And it's important to mention that these drugs are used for colon cancer as well, but they are used only for disease that has spread outside the rectum or stage 4 disease. So either for disease that's recurrent or for patients who have stage 4 disease at initial presentation. We do not use these drugs for early stage disease, nor is there any evidence that there's an advantage to doing so. Next slide. Surveillance involves periodic screening and tests to see if the cancer has come back. Patients with early stage rectal cancer who've been successfully treated are advised to remain in a monitoring program for a 5-year period. The monitoring gets progressively less intensive over time, but is typically every 3 months the first year starting at the end of treatment, and then every 6 months during the second year, and it continues on an every 6-month basis up until the 5th year. Surveillance consists of history and physical examination, and this is done at every surveillance visit. CT scans, which need to be done only annually or in the event of an unusual new symptom or abnormality. Colonoscopy to re-evaluate the remaining bowel. Obviously, some has been removed as part of the operation, but that needs to be done a year out from diagnosis, and then based on the findings at regular periods thereafter. If that first colonoscopy a year later is normal, the typical recommendation is to have another one 3 years later, although that recommendation may be different if there are more polyps that are found or if there's a very strong family history. Blood tests, including the CEA test that I mentioned earlier, are also an important component of those surveillance follow-up visits. Next slide. So I just want to mention an example of the kinds of research studies that we're doing. And I'm going to talk about a clinical trial that is now open and accruing nationwide. This clinical trial is called Prospect, and it is for patients with stage 2 and 3 rectal cancer. Stage 2 and 3 rectal cancer are often lumped into a group and called locally advanced rectal cancer. This research study is being done to see if radiation can be avoided for a select group of rectal cancer patients who have a good response to 6 treatments with the chemotherapy combination regimen known as FOLFOX, which I told you about a few minutes ago. The proposed study doesn't use any new chemotherapy drugs or procedures, but rather sequences the existing treatments that we have in a new and different way. Next slide. Why are we doing this study? Well, right now we treat stage 2 and 3 rectal cancer in 3 phases. This is not easy. I often tell my patients that they have to think of climbing 3 mountains, surmounting 3 hurdles. Rectal cancer is hard because treatment is long and it's a bit more complicated than the treatment for colon cancer. The first mountain, the first hurdle that rectal cancer patients have to overcome is a 5.5-week treatment with chemotherapy and radiation given together. This is called chemoradiation. Why do we do this? We do this to prevent the rectal cancer from coming back in the same location in the pelvis. Rectal cancers, unlike colon cancers, are very likely to recur in the same spot. When rectal cancer comes back in the pelvis, it sits near all those important structures in that small space, and it can cause lots of pain and discomfort and really impair quality of life. We know from good studies, randomized trials done about a decade ago, that the chemotherapy and radiation, when given together, work better when you give it before surgery. Quality of life of patients is better, and the chance of preventing the tumor from coming back in the same spot is lower, and that's why it is important that the chemotherapy and radiation be given before the surgery. After about a 6-week period of recovery, the next step is surgery to remove the tumor itself with the important resection that should include the TME procedure. Rectal cancer surgery these days is about 5 days in the hospital. For folks with some other medical problems, it may be a bit longer, but between 5 to 8 days in the hospital is reasonable, followed by, again, another 4 to 6 week recovery period. So you can see that rectal cancer treatment is long. 6 weeks of chemoradiation, another 4 to 6 weeks of recovery, approximately a week in the hospital for surgery, another 4 to 6 weeks of recovery, and then the final phase, which it's probably the easiest for most patients, but it's also the longest, and it comes at a point when folks are already tired, and that is chemotherapy by itself with the FOLFOX. The FOLFOX chemotherapy is given every 2 weeks, typically for about 8 treatments, which is about a 16-week period, so 8 treatments every 2 weeks adds up to 16 weeks, or about 4 months. And the FOLFOX chemotherapy is given intravenously during a few-hour session in a physician's office or the outpatient department of a hospital or clinic by a chemotherapy infusion nurse. And most patients who receive the FOLFOX regimen then wear an intravenous pump that delivers the chemotherapy drug 5-FU over 48 hours. So that's given for 48 hours, and they're then disconnected. Most patients are able to disconnect the catheter themselves very easily, and then are free for 12 days, and quality of life during this time is very good for most patients. What's the purpose of the chemotherapy? The purpose of the chemotherapy is to prevent the cancer from setting up shop in a distant organ like the liver or the lungs. And again, important to remember what is the purpose of each of these 3 phases of treatment. The purpose of the first phase is to shrink the so the surgeon can do the best operation possible, and to prevent the tumor from coming back in the same spot. The second phase is to the tumor. And the third phase is to prevent the tumor from returning in a distant organ. Next slide. Why is this study being done? Why are we doing a prospect trial? Well, we've learned that with modern surgical techniques, better chemotherapy, and the availability of MRIs that let us characterize just how invasive these tumors are so precisely with our better imaging techniques, it is now possible that some patients can actually avoid radiation to the pelvis. So if people need radiation, we want to give it to them. But if people don't need radiation, we don't want to expose people unnecessarily if we can cure them another way or an easier way. Chemoradiation has side effects, and so it would obviously be valuable to avoid it for patients who can achieve good results without it. As rectal cancer specialists, we really hope that giving FOLFOX chemotherapy before surgery will enable some rectal cancer patients to avoid the chemoradiation. It's important to remember that the chemoradiation is a daily treatment, Monday to Friday, not on the weekends, for 5.5 weeks. And it's quite arduous and difficult for many patients. Many tolerate it quite well, but simply, even without a lot of side effects, just going back and forth to get the treatment every day is quite arduous. Next slide. Why we're doing the prospect study. Well, as I said, radiation treatment is time-consuming and involves daily visits. We know that radiation often has long-term effects on bowel, bladder, and sexual function. We know that radiation in previous clinical trials does not improve overall survival rates from rectal cancer. It is very important in decreasing local recurrence rates. We don't want people to have local recurrence because we know those are miserable and cause symptoms. But we think that because these other techniques have gotten better, that the local recurrence rates have come down, and this trial is questioning whether there isn't an easier way to achieve the same good results. So we hypothesize that radiation treatment may be unnecessary for some carefully evaluated patients with early-stage rectal cancer. We think that better imaging, better surgical techniques have made it easier to carefully stage patients and figure out who does and doesn't need radiation. We do not know yet what the best way to treat this disease is until we carefully compare the approaches in prospect, which involve giving some patients the standard treatment of chemoradiation and other patients FOLFOX. Obviously, as researchers, we think that this is promising, but we don't know until we do the studies, and we can't do that without engaged patients, engaged communities, engaged family members, helping people understand just how important research is to our making progress. Next slide. So what's the standard treatment look like? Again, I alluded to this before. It's 5.5 weeks of radiation with 5-FU-based chemotherapy, 4 to 6 weeks of recovery, surgery, 4 to 6 weeks of recovery, and chemotherapy for 3 to 4 months or 16 weeks. Next slide. The investigational arm of this study involves giving chemoradiation selectively to people who do not have a good response to FOLFOX chemotherapy. Patients who are randomized, and this is a randomized trial, patients who are randomized to the intervention arm receive 6 FOLFOX treatments, and because it's every 2 weeks, that's 12 weeks, which is approximately 3 months. After these 6 FOLFOX treatments, patients undergo re-evaluation, which consists of repeating the MRI and having the surgeon re-examine the rectal tumor, again, very carefully. After reviewing the MRI, and the MRI is reviewed again by the surgical oncologist, the medical oncologist, and the radiation oncologist, and a determination is made as to whether the tumor is responding or not. most of the time we anticipate that patients will respond to FOLFOX. In the unfortunate event that a patient does not respond to FOLFOX, there is then the opportunity to go ahead and down, this is the bottom of the slide, and deliver the 5-FU with the radiation, then the surgery, and then the postoperative chemotherapy. So if the chemotherapy doesn't work, then we can give the chemotherapy and radiation. And postoperatively, physicians would not choose to give more FOLFOX because we've already established in such a patient that it is not an efficacious regimen. It didn't work. So this would enable physicians to try something else. For those patients whose tumors do respond to chemotherapy and have a nice response to chemotherapy, the idea is that these patients proceed directly to surgery without receiving any preoperative radiation. Those patients then, after recovery, would go on and receive an additional 6 treatments of FOLFOX, and for a total of 12 treatments of FOLFOX. And for those of you who know about colon cancer, you know that 12 treatments with FOLFOX is our current standard for colon cancer. So essentially what we're trying to do here is, for people whose tumors melt beautifully to FOLFOX, we're trying to not give them the radiation and thereby sparing them the inconvenience, discomfort, and potential quality of life effects of pelvic radiation. But if people's tumors do not respond to FOLFOX, then we are giving them the radiation and will avoid giving them further FOLFOX because it would make sense to give them a treatment that isn't effective against their particular tumor. Next slide. So if you know anyone who might be interested in Prospect or, frankly, any other colorectal cancer clinical trial, a great and reliable source of information can be obtained from the National Cancer Institute, and I have the phone number here. The website, really, this is reliable information, is cancer.gov/clinical trials or cancer info. You should know that as physicians, we're always telling the NCI that they need to update the website, they need to make it more user-friendly for patients and, frankly, for us as well. Because for example, today I had a patient call me from Louisville, Kentucky, and I practice in Boston, Massachusetts, wanting to know about what clinical trials were available in Louisville, Kentucky, which is not something that I know off the top of my head. And so I need to go to these websites. And they're not quite as user-friendly as we would like them to be, but they are very complete. And I know the NCI is working continually and welcomes feedback from engaged patients and families. So you should definitely use the site and also send them your feedback and comments. If you have additional questions or would like information about Prospect, you should by all means contact me at the Dana-Farber. And you can also look at the specific information about the Prospect trial on cancer.gov. This clinical trial is available. I'm not sure if it's in all 50 states. I'm not sure we're open in Alaska yet, but I believe we're open in about 46 states across the United States. So it's widely available also in Canada. And the protocol coordinator's email is also posted here. Mr. John Taylor at the University of Chicago. And we really can't do these research studies without patients and families and everyone really pulling together so that we can move forward and do a better job treating this disease, really keeping our eyes on the long term because we don't want to impair people's quality of life. We want lots of survivors and survivors who feel that their disease has been treated with minimal impairment on their ability to function well and feel well over the long term. So I think I'll stop there and take questions.
Okay, great. Thank you so much, Dr. Schrag. And I have to tell our listeners tonight, it's not every day that you get the email address of a very prominent physician such as Dr. Schrag. So it's great of her to provide that if you're interested in the prospect trial. And I would also echo her comments about sometimes cancer.gov, it's not all that easy to navigate as a patient. And you can certainly, if you're interested in the prospect trial, contact Dr. Schrag herself. Or also if you contact our answer line here at Fight Colorectal Cancer, we have partnered together with an organization that can help you search for clinical trials in your local areas according to the biology of your tumor. So feel free and contact our organization as well if you have any questions about further clinical trials. So
Right,
thank
and I should probably say I can't dispense medical advice by email. Obviously, that's disrespectful. It's just disrespectful because medical care is more complicated than that, but if I can quickly, provide a recommendation or triage people, then I'm happy to try to do that.
Of course. No, it's a perfectly acceptable disclaimer. So hopefully folks will contact you about the prospect trial. So a couple questions have come in prior to the webinar and during the webinar tonight. So let me just run a couple by you. In terms of new drugs that are being tested for late-stage rectal cancer, are you aware of any? You mentioned some of the chemotherapy regimens in your presentation. Are you aware of any new chemotherapy regimens or biological therapies or targeted therapies that are being studied in rectal cancer?
Yeah, so there was a drug that was approved last September called regorafenib that it was approved at the end of September by the FDA. So, we're gaining experience with it. It's been around for a while. We used it during clinical trials, and now, it hasn't even been a year, so many physicians haven't treated a lot of patients with it. The drug is quite similar to another drug that we use to treat liver cancer, and that drug is called sorafenib. So, again, they're fairly close cousins. It's a little bit hard to interpret how well that drug works because it's been given in a situation that's called third line. So these are people who've been treated with multiple. They have advanced colorectal cancer and they've received multiple previous cycles of chemotherapy and types of chemotherapy. So not everyone was necessarily super healthy going into the study. And it was compared to placebo, so people who got a drug that was inert. And in that context, patients who received it did live longer, but I wouldn't call this a home run. This is not years longer. This is on the matter of a few months longer. The main side effect is something that we call hand-foot syndrome, which is really kind of a red rash on the palms and soles, which not everyone gets, but when people get it can often be quite debilitating and almost always requires reducing the dose or taking a break from the treatment. So that's one new drug. There's another new drug called Zaltrap that's really a very close cousin of bevacizumab or Avastin, a drug that we already have. So you don't see much excitement on our part because it really is kind of a Me Too drug, so we weren't so excited about that one. And then at the moment in the clinical pipeline, of course, are numerous drugs that are being tested in phase 1 trials, and many of these drugs, still have numbers, don't even have names yet, but they're not yet FDA approved.
Okay, great. And one of the questions that came in actually relates to regorafenib. So the brand name of regorafenib is Stivarga. And one of our attendees had written in that she has heard about Stivarga. And how do you know about its effectiveness after Vectibix? I know you talked about it being in third line, but if you want to answer the direct question of it being effective after Vectibix.
It can work. I would say that, people really need to think hard. If somebody's been on Vectibix or cetuximab and they're still recovering from a rash and they're really exhausted, they might want to take a little bit of a break. But again, that's the kind of thing that you should discuss with your individual physician very carefully. Sometimes going right from one chemotherapy directly into another without a recovery period can backfire if people don't have a chance to gain some weight and get some of their strength back. And for other people, it is the best option to go right from one treatment to the other. So, that's where we get into a lot of the specifics of a particular individual case. But, some people can tolerate regorafenib quite well, and others can have a very hard time. People who are not able to eat 1,500 kilocalories a day, people who are not able to spend more than half the day out of the bed are going to have a hard time. So, we see people get into trouble when folks who are really frail to begin with start on this drug. It can often backfire. But folks who are pretty fit and healthy can do pretty well on it. And what's nice is it is an oral pill. I think we're going to know a lot more about how this does in a much larger population over the next couple of years because, again, it really has only relatively recently become available.
Okay, great. And another attendee writes in that that he or she was given mitomycin for chemotherapy. Is that usual or unusual?
It's pretty unusual these days. Mitomycin is still used for anal cancer. It's a very old drug. It was actually around way, way back when all we had was 5-FU. We had 5-FU and mitomycin. It has a lot of nasty side effects. And we, for the most part, don't use it. Sometimes folks will use it when, frankly, they've run out of other options or a clinical trial isn't available. But we, for the most part, it's not something that we use very often anymore.
Okay. And one of the attendees says that his or her father had rectal cancer, and then unfortunately it mets to the liver and now metastatic disease to the lungs. And he's been on Avastin and is now on Vectibix. And is there, in addition to what you've already mentioned, is there any developments in late-stage metastatic colorectal cancer that other than what you've already mentioned?
I wish there were more. We're trying to target specific molecular subtypes. But again, I would make sure that this individual's father has, discussed the treatment FOLFOX, discussed the treatment FOLFIRI, and that the physicians have really gone very carefully and made sure that there is no evidence that those treatments would work or that they, would be tolerated. But FOLFOX, FOLFIRI, and then trying either Vectibix or cetuximab, either one, it doesn't matter, they're interchangeable. Either one of those drugs, and regorafenib, I think we discussed previously.
Okay, and then two questions actually came in with relation to side effects of chemoradiation therapy, and one of them specifically is what can be done for patients post-treatment suffering from the effects of radiation treatment. For example, sexual problems, bowel, and bladder problems. What do you suggest for your patients?
So the first thing is to be patient. So a lot of the effects wane over a few weeks. So I don't know if this is somebody who's just a few weeks out from chemoradiation or somebody who's months out. The answer is a little bit depends. If it's someone who's just a few weeks out, they should sort of be kind to themselves, do as much as they can to distract themselves because it's going to get better. It gets a lot better. The question is, does it get all better? You should be in close contact with your clinical team, which may consist of, physician, nurse practitioner, sometimes a physician assistant. And you have to figure out with them, they will give you the tools, but then you have to figure out what is the best regimen for you. I have patients who Imodium works for them. I have other patients who Lomotil works for them. I have other patients who take tincture of opium. I have many patients who figure out that they can't do fresh fruit and vegetables or that they have to avoid certain kinds of foods. People figure out what the foods are that irritate their bowel and what the foods are that make them need to run to the bathroom 5 times a day. So people typically figure it out. Sometimes working with a nutritionist is really helpful. It often depends whether or not people have an ostomy. For both men and women, I think the key message is don't be afraid to address the sexual function piece with your providers. I think if you just finished chemoradiation 2 or 3 weeks ago, in my experience, most of my patients, that is not a time where their really focus is on their sex life because people are still recovering And honestly, if you go to your physician 2 weeks after finishing chemoradiation, they're going to be amazed that that's your focus then, and they'll say, give it time, give it time. But if, on the other hand, you're talking about post-operatively, and these are issues, definitely bring it to your attention and recognize that it's quite possible that the primary members of your oncology team, they may not have the expertise in sexual health. If you're a man, you may need a referral to a sexual health expert or a urologist. If you're a woman, you may need a referral to a gynecologist. You know, oncologists vary widely in their training and familiarity with this topic. If your physician is a clinician who mostly treats rectal cancer, they probably will be quite familiar with it. If they're a general oncologist who treats all kinds of cancer, they may be less familiar with this. And even a one-time consultation with a sexual health specialist can be very helpful. For women, for example, things like a little vaginal estrogen, or sometimes the estrase ring, or particular types of lubricant can be very helpful. One of the things that pelvic radiation does is it creates what we call fibrosis of the tissues. As the tissues get sort of hard and dense and less flexible, and literally need to be stretched a little bit. If that doesn't happen, then intercourse can be exceedingly painful. And they actually make what's known as vaginal dilators. The radiation oncologist and the medical oncologist can write prescriptions for these vaginal dilators, and there's some exercises that they show you how to do. And by adhering to this, when you get done with radiation, it can help preserve sexual health. But don't despair, even if you didn't do that. There are lots of techniques, and you know, if someone just says, well, here, try some KY jelly and go to the drugstore and buy some lubricant and that's it, you know, we could do better than that. Again, it's an uncomfortable topic sometimes. Sometimes if the patient is female and the physician is male, it can be hard. But I would say you have to be assertive. If you feel uncomfortable talking to your physician, talk to a nurse. Hopefully no one's uncomfortable with their oncology team, but a team member should take your concerns seriously. And if that isn't happening, I would, for women, definitely suggest your OBGYN, and for men, definitely urologist. You know, drugs like Cialis, Viagra, they can be helpful for men who have difficulty maintaining adequate erections after pelvic radiation, but, you know, do not despair. Usually, in the short term, people's first concern is sort of getting the bowels normalized again. And once the bowels are normalized again, people tend to turn their attention to sexual function. But really, we are able to help not everybody, but most people maintain, you know, rewarding sex lives even after rectal cancer treatment.
Okay, great. And yeah, actually, the webinar that we brought to you tonight here is part of a monthly patient webinar series. And if you look at some of the archived versions, we actually had a webinar on the sexual side effects from rectal cancer. So you could preview that webinar as well.
So hopefully I didn't contradict anything in that one.
No. Actually, it was right in line with everything that was said on the webinar. So just so a couple more questions. If someone has metastatic disease to their lungs, is there a certain size of a tumor in the lung that should cause for concern, or is anything that's spotted there a concern?
So the answer is it really depends. There's no one magic number. So what I would say is, you know, things that are very, very small, under a centimeter, it's often it's difficult to biopsy things that are that small because it's so easy to miss. And they often don't show up clearly or consistently on scan. So I'm not talking about things that are teeny, teeny, tiny, but things that are over a centimeter. People wonder what's the best way to treat them. If there are multiple lesions, particularly if they're in both lungs, the best way to treat that is with chemotherapy. Because cutting it out or radiating it when there are multiple spots, you can't radiate the entire area, and you can't cut out both lungs. If it's really sort of in there like freckles all over, like chicken pox all over, you know, we wouldn't operate on chicken pox either, right? If it's a diffuse process. If they're just a couple of lesions, particularly if they're in one area of the lung, then sometimes we will try to operate, particularly if we think it's all just in one lobe or one wedge or one segment of the lung. And people often say, well, what's too big to operate on? It's not just the size, it's the location. So it depends where the tumor is in relation to other structures like the great vessels of the heart. Is it right on the outer edge of the lung? Is it sticking next to a rib? So sometimes you can have a tumor that's 2 centimeter that can't come out, but you could have a 3 centimeter tumor that can come out. So it's not only size, it's what the tumor is sticking up against, what it's stuck to, where it's located with respect to blood vessels and airways, like, for example, the trachea and the bronchi when you're talking about the lung. And that's why people often say, well, what's too big or what's impossible? That requires a trained thoracic surgeon sitting down and reviewing the x-rays with a qualified radiologist and putting their head together with, it's usually the medical oncologist who knows the patient well. And this is where it really, and rectal cancer is a team sport. It's team decision making. So when I have a patient with advanced rectal cancer that it's in the lungs, I will review the x-rays, and it's usually a CAT scan. I will review the CAT scan with radiology. I will review the CAT scan with a thoracic surgeon. And of course, I will get input from the radiation oncologist who treated the patient usually initially. And we often bring the colorectal surgeon in. Even though the colorectal surgeon doesn't operate on the lungs, they have expertise with how difficult or easy was it for this particular patient to undergo surgery. And that may inform the optimal treatment choice. So again, lots of people put their heads together, and that's really how the best medical care is delivered, with teamwork.
Okay, great. Then it's reassuring for patients for sure. So is it possible, for example, to go back to standard chemotherapy after a patient, for example, has been on Avastin or Vectibix?
So it really depends on the reason why it was stopped. So if chemotherapy was stopped because the cancer progressed, then the likelihood that it's going to work again is really low. The exception to that is if there's been a very long interval, or if the treatment was given in an early stage setting. So if somebody got FOLFOX when they had no disease, like for locally advanced disease in what we call the adjuvant setting, and now it's been more than a year, and a year is kind of a rough rule of thumb, it's absolutely worth trying FOLFOX again. But if someone received FOLFOX in January and February, and then a CAT scan was done that showed that the cancer was growing even though they were getting FOLFOX, you wouldn't try FOLFOX again in May, because that tumor is resistant. If somebody has strep throat, and the best analogy I give you, someone has strep throat and you give them penicillin, and then a week later they have another sore throat, you're not going to give penicillin because you presume that it's bacteria that are resistant to penicillin. You're going to try a different antibiotic. But if they get a sore throat a year later, you'll try penicillin. So it depends on the interval, how long it's been since they last saw the chemotherapy. So I know it's sort of a complicated answer, but I think that sometimes thinking about that antibiotic analogy may be helpful to people.
I agree. I love analogies. So just a couple more questions if you can give us a few more minutes. Lung surgery, is it doable for somebody who has metastatic disease to the lungs for a man, for example, that's over the age of 70?
So again, we don't use hard and fast age cutoffs. Some people who are 70 just can't go to the operating room. It's too dangerous. It's not safe. It's not going to work for them. However, other people who are 70, some people 70 is the new 50, and some people 70 is the new 90. So, 70 with a history of high cholesterol, hypertension, diabetes, cardiac risk factors, and a little, heart attack, absolutely not. But, fit, healthy 70-year-olds, may be worth considering. Again, if the lung nodules are in both lungs, they're growing, there are lots of them, it's not worth doing. But that's what a good thoracic surgeon can assess.
Okay, and you talked a little bit about this during your presentation, but I want to go ahead and ask the question anyway. What do you think about neoadjuvant FOLFOX for a non-metastatic rectal cancer patient and chemoradiation in addition to the treatment?
So neoadjuvant FOLFOX, that is the strategy that we're testing in the prospect trial. So I would say, find a site that's doing the trial.
Okay, good. I like that answer. That's great. Let's see. And a question came through about the slides being available. They will. They will be available probably tomorrow. The webinar will be archived and the slides will be available. And let me just see. I think we may have one additional question. Let's see. Is it possible hang on. Where did it go? One second. Please hold. I want to make sure we get everyone's questions in. Is it possible to go back to standard chemotherapy after having tried, for example, Avastin or Vectibix? Actually, yes, you answered that one for us.
Yeah, I think I answered that one.
Yep, you did. That was my error, and I think that'll just about do it for the questions for tonight. Actually, no, there is one more. How important is it for people to avoid other sick people, or sick people when they're actually on a chemotherapy regimen or Xeloda or even one of the oral chemotherapies?
It's not particularly important. It's not like leukemia therapy where the bone marrow is terribly suppressed. So almost never do colorectal cancer patients need to avoid other patients while they're on chemotherapy. It's very rare.
Okay, great. Well, I think that will just about do us for tonight. If other questions have come in that I have not quite seen yet, we'll be sure and obviously get those questions answered for folks. But I can't thank enough our presenter tonight, Dr. Deborah Schrag, as well as our attendees. And like I said, the slides will be available and the webinar will be archived in case you want to go back and review anything or direct some of your friends or family members to the webinar. So thank you so much to our attendees tonight, as well as our renowned physician. And please feel free and contact us at Fight Colorectal Cancer if you guys have any questions. And thanks again to you, Dr. Schrag, for your presentation this evening.
Bye-bye.
Okay, thanks. Bye.